about 4 o'clock today, you'd be saying, when do we get to ask the questions? Right. So with that in mind, I just thought I would try and give us perhaps maybe a limited introduction, if I may. Immediately to my left is Assistant Dean Kimberly Mutcherson from Rutgers University School of Law. I know she's doing good things there because I also went there. Dr. Mutcherson is a phenomenal panelist. Her experience and her background are extensive, both with respect to her involvement in all sorts of activities and a phenomenal number of publications. So we're very lucky to have her, and welcome. Thank you. Next, at the other end of our table, we have Dr. David Gorden. Dr. Gorden is a professor at Shippensburg University. He also has an extraordinary curriculum vitae. He is just extraordinary in terms of all of his accomplishments. He's worked in any number of areas. He has a special interest in environmental issues and also ethical issues. We're very fortunate to have Dr. Gorden as well. Thank you. To Dr. Gordon's immediate right is Dr. Stephanie Sober. I have heard Dr. Sober speak before, and I've reviewed her background. It's extraordinary. She would also be one of those folks that would keep us here till 4 o'clock if we went through everything she's done. Let me say that she is very experienced and very knowledgeable, a list of amazing publications and involvement with this field. So thank you for coming, Dr. Sober. And last but certainly not least, Marcella Nyachogo. She's our social work expert. She also comes to us with a wealth of experience with respect to some of the many issues that we'll see today. So without further ado, I want to welcome her as well, and thank you all for coming. And thank you all for our moderators, and thank you all for those of you that have participated in this process. It's one in which we will now work on getting the questions that you formulated and asking our experts to get their input on this. One of the things that's sort of a background rule that I hope you would understand is that if from their questions you have other questions, I'm not sure we can just work those out. We need to get through all of our panels first of all, and then really the idea is that we use the questions that you have formulated for now, rather than sort of freestyling as we go. Thank you for that. So without further ado, can I get a where's our? I guess our tables are set up 1 through wherever. Yeah. And where's our first table? First table. Do we have a volunteer that will read the question? Very well. Tell us your name, and if you would, your name is.
Stephanie.
Okay, that's definitely give you this, and I'm going to let you read the first question if I could. You are.
Would a personhood amendment have an impact on public policy other than abortion?
Sounds like
a new question. Oh, here we go. There we go. Yes. So one of the things that's really complicated about personhood amendments is that they potentially have significantly broad impact outside of abortion, and one of the obvious areas is for assisted reproduction. So if it is the case that an embryo is a person, and you're a person who's running a fertility clinic, then those thousands of embryos that you have frozen that people may or may not want to use are people. So just imagine, there were a couple of cases this summer where fertility clinics had power outages, things happened, and a bunch of embryos got destroyed. Now, the question that people are sort of sorting out now is, what kind of loss is that, and how do we deal with that? If you had a personhood amendment, maybe that loss is murder, right? Or maybe that loss is negligent homicide. So there are lots of ways in which personhood isn't just about abortion.
What has been the impact of dividing pregnancy into 3 trimesters on the development of abortion restrictions?
You're a doctor or a lawyer, I don't know. Yeah. So I'll do it from the legal perspective. So in Roe versus Wade, the 3-trimester framework was central. And Justice Blackmun basically, or the court, because the other justices, most of the other justices agreed to it, they divided up abortion regulation based on what trimester you were in. So first trimester, the state can't regulate at all. Second trimester, the state can regulate, but only for the woman's health. And then third trimester, the state has a compelling interest in potential fetal life and could ban abortion altogether unless it was necessary for the life or the health of the pregnant woman. Post Planned Parenthood versus Casey, which was decided in 1992, and that was a Pennsylvania case, the court said that rigid trimester framework doesn't give enough effect to the state's interest in potential life. So now we're not going to use the trimester framework anymore, which was always sort of destined to fail anyway, because as science gets better, those trimesters start to really bleed together. But now the standard is viability. So at the point of viability, which again is not a static thing, at the point of viability, that's when the state's strong interest in potential life kicks in.
And I guess the relevant thing from the medical point of view is that, the trimesters, when they started, it's just sort of an arbitrary thing, it's sort of end of the first trimester. Some people actually would say it's 12 weeks, 6 days. Other people would say it's 13 weeks, 6 days. And so it doesn't really mean all that much in reality. It sort of was just, I think, a framework for them to really be able to sort of divide who would have jurisdiction or the ability to sort of legislate. But again, even that viability time point is really a moving target, and with technology getting better and better, that has sort of moved earlier and earlier, though it still sort of depends on, where you're located and what resources and hospital, what type of intensive care nursery you have access to, whether those early targets would be applicable.
I will move now to table number 2, and if we've got a volunteer, we could read your question number 1, please.
Okay, good afternoon, panelists. This is Robin Robinson. Here's my question. What are the best social influence methods that can be used to persuade moral, conservative individuals to refrain from imposing their own individual morality through law in terms of abortion? Did you need me to repeat? What are the best social influence methods to persuade moral conservative individuals from refrain imposing their individual morality through law pertaining to abortion?
The next day, I think we all like to know.
I think this goes back to the Constitution, right? Is the right to privacy in the Constitution? If not, then should this be legislated, right? Should we be electing people, Congress, to be kind of passing laws? And I think that was Rehnquist's position. I, as a male, I might respect life, or at least hold a strong reverence for life, but again, I don't feel like I have the right to tell a woman what she has to do with her body. So I feel like, is this an issue that should be decided by the state, what a woman can or cannot do with her body? Or is it something which she herself has to decide? And I think what you're asking is do conservatives have the right to tell women what they can and cannot do with their body? And so it's not just about the fetus's right to life, or the mother's right to do with her body as she wishes. It's also an issue of self-determination and the right to liberty. And even I think if a conservative feels strongly that they should not, that a fetus does have a right to life, they still don't have the ability to impose their views on other people. And so that you have to listen to what the government says. I think kind of the question of what you're asking us is, does the government have the right to tell individuals, override their right to autonomy, and tell them what they can and cannot do with their body? And we are America, and I think even if you are pro-life, you have to recognize the autonomy of the individual here. So you might, this handout did a very nice job of saying there's no, it's not really a black or white issue. You can be pro-life and still be pro-choice because you feel like this is a very tricky subject and it should be left up to the individual while you can at the same time be pro-life. That helps.
I wanted your perception though, as a moralist.
Yeah.
So thank you.
Can I just say one thing on that?
Sure.
I think that's right in a sort of practical sense, right? And there are all these sorts of questions about what the government can and can't do and should and shouldn't do. But I think when it comes to abortion, one of the things that's really tough in the context of trying to persuade people who are anti-choice not to impose their values on other people is if you truly believe that a fetus is no different than a kindergartner, what kind of person would you be to not try to impose your values on other people, right? And so that's what I think is really hard. You know, the same people who would say, I don't want people to, you know, poison the water in Flint, right, because those are children, would also say there's no difference between those children and what goes on in an abortion clinic. And when that's what the divide is, I think it's really, really hard to push somebody in a different direction.
Thank you. Group number 3, do we have a volunteer to read a question?
Good evening, panel. The question is, what are the factors and stages that determine when the fetus is given rights? What are the factors and stages that determine when a fetus is given rights?
That sounds like a me question. So when Roe versus Wade was decided in 1973, one of the things that Justice Blackmun said in that opinion and that the court agreed to is that a fetus is not a constitutional person, right? And so that means that a fetus doesn't have constitutional rights, but it doesn't mean that the state can't have interests in a fetus, just that the fetus itself is not a person who has constitutional rights. That continues to be the case. There are some states who, you know, have pushed the envelope on that, but the foundation remains that a fetus is not a person who has the access to rights that an individual out in the world would have, and that's still the law.
Yeah, again, pro-life, pro-choice, it tends to be polar, right? It's either at fertilization or at birth, but there's all sorts of shades in between, right? Including sentience, the ability to sense pleasure and pain, which is in the middle of the second trimester. Quickening was one of the traditional ones where the baby starts moving. And I would say now it's viability. I mean, I really think
But that's not about the fetus having rights. It's about the level of interest that the state has in the fetus.
right. I'm just saying that there's different criteria for determining the moral status of the fetus, but you're right, rights is a different matter.
Okay. All right. Can I get a volunteer for your first question?
My question is, there are negative connotations with the word abortion. So why do we call it abortion if the health of the mother is in genuine distress and there's a chance of death? Is there another medical term for this?
That sounds like that's my area. So actually, you know, the correct medical term for any type of pregnancy loss is abortion. So even the correct medical term for a miscarriage is what's called a spontaneous abortion, meaning that the pregnancy either passed or if it hasn't yet physically expelled, that, if the heartbeat stopped, we still would call it a spontaneous abortion, meaning that happened on its own, but that's still the same term, in contrast to an induced abortion, which would be the term for an abortion that someone elects to have, or ending the pregnancy, by choice.
Yeah, so for me in practice, because we know it does have such a connotation, what we usually talk about with clients who are sort of talking about this or contemplating this is we ask them, like, what would you like to do about this pregnancy, right? Because it puts, from a social work perspective, like, it puts the client in control, and it doesn't put my beliefs about whether that fetus is a child or not a child onto that person. So it's really about, like, how would you like to move forward with this health issue that you're experiencing right now? And then we sort of let the client tell us what language works for them.
I just want to say one thing about how language functions here. So I do a lot of abortion-related work, but I also do a lot of work on assisted reproduction. And it is the case that, let's say you are doing IVF or you're taking medication and you get pregnant, you get 2 pregnant, right? You're pregnant with 6. And you don't feel like, and for good reason, that you can carry 6 to term, your reproductive endocrinologist is going to say to you, we can offer you a selective reduction. They'll never use the word abortion. We're going to offer you a selective reduction, and we can make you pregnant with twins instead of pregnant with 6. And so that's a pregnancy that you can handle safely, and it's safer for the fetuses that become a child. And the folks who do that kind of work are very careful not to call those abortions, because they recognize that once you say abortion, you're in a whole different set of circumstances and conversations. But if you say a selective reduction that's meant to allow the pregnancy to continue safely for the fetuses that remain, people tend to think about it really differently. That's right. And the same laws don't apply to selective reduction. So there's no 24-hour waiting period. There's no forced informed consent. None of that.
Thank you. Do we have a volunteer for a question here?
Hello, panel. Oh, hello. Hello, panel. My name is Jasmine. I'm a student at Picket University. Being that we have cases like Gosnell, the question that I have to ask is how do we better regulate facilities for low-income neighborhoods?
I'm just going to dominate. One of the things that's really interesting about the Gosnell case is that it happened in Pennsylvania, which has some of the strictest laws on the books about regulation of abortion facilities. So the problem wasn't about the regulation, the problem was that the state wasn't enforcing what they already had on the books. So I don't think it's a question of do we have enough rules, it's does the state truly care enough about women to be enforcing those rules that they do have that are supposedly meant to protect women from bad providers like Dr. Gosnell.
I think, just to point out that, a lot of these state regulations that are made, the professed intent behind them is to ensure the safety of women, and so, it just sort of shows you that, they exist, and unfortunately, things can still happen that are not appropriate. I mean, that was, Gosnell, just to be clear for everybody in the room, was a criminal, so that is not, he was not acting as a physician.
Do we have a volunteer for your question?
Hi everyone. Our question was, is there any research on the number of reasons why people have abortions?
I'm sorry, can you just say
Any research on why women have abortions?
okay. Yes, there is, certainly a lot of research out there as to the reasons that women do choose to end pregnancies, and as you might imagine, it varies from woman to woman, but certainly There is a body of literature out there, but it can range from this is not the right time for me to this was a desired pregnancy that went horribly wrong because there's either a genetic abnormality or some other fetal abnormality. So it runs the gamut. But yes, that is something you can find, in the literature.
Okay. Our volunteer here? Yes.
Good afternoon. When it comes to an abortion, is there a specific specialty of a physician in order to perform the abortion? Like, for example, could a cardiologist perform abortions versus an OBGYN?
So technically, yes, they could. I'm not sure that they would want to venture out of their area of expertise. So, the answer to your first question in terms of is there a specialty, yes, but those are not the only folks who are trained to provide abortions or who are able to provide abortions. So the specialty would be that there is a subset of folks who are trained in obstetrics and gynecology who then go on to pursue fellowship training, which is additional training after your residency in OBGYN in what's called family planning. And again, it's kind of a confusing name, and a lot of people think it refers to fertility work, but it actually is essentially means contraception and abortion care. You do not certainly have to be fellowship trained to be able to provide abortion care safely. I will say just from the outset, abortion is one of the safest procedures and is actually one of the most common procedures that's performed for women, second only to cesarean section. So certainly any OBGYN would have the skills, since it's actually the same procedure you do when a miscarriage occurs. So any OBGYN really should have the skills to do this. It's just a matter often of whether that person chooses to do the same procedure when there is still a heartbeat present. Yes. So in addition to, I'll get there. In addition to OBGYNs, there are folks in other fields who also provide this. So some family medicine practitioners also feel that abortion care is part of kind of comprehensive reproductive health care. There are some pediatricians even who will provide these services. And in certain states, nurse practitioners or physician assistants, other advanced practice clinicians are able to also be providers.
Right. Can I get a volunteer here?
Hi. So one of the things that came up in our conversation was what happened after Texas kicked Planned Parenthood out of the state and started the Healthy Texas Women program, and how they gave grants to clinics that didn't provide abortion, but also didn't really provide other services either. And now we're starting to come back to learning that those clinics who applied for the grants and said that they could serve X number of women were serving fractions of that number and are still getting their grants renewed. So our question is, how is money driving the legislation and regulation of abortion at the state level?
I mean, I will let others, answer as well, but I think, I'm not sure that it's so much about the money there. It's just that because Planned Parenthood was serving as such a safety net organization and would see so many either, uninsured, underinsured, or Medicaid patients, that when Planned Parenthood gets defunded by a state, and just to clarify for everyone what defunding means, it means that the state Medicaid would no longer reimburse Planned Parenthood for seeing Medicaid patients at their facilities. So it's not that there was this pot of money that the government would give to Planned Parenthood regardless, it was just that if Medicaid patients chose to get their care there, they would be reimbursed through Medicaid by the state. So unfortunately, when you remove the safety net provider, there really weren't other providers that were able to provide the same level of reproductive health care, either in quality or in quantity. And so a lot of those lists, you know, it came out, had, you know, dental offices on them. Well, certainly you're not gonna get STD testing at your dentist's office, so that's not what they do. So I think, you know, they're finding that they're having to give grants to places because those are the places that exist now. Since many of the Planned Parenthoods, you know, were forced to shut down. And it sounds like from your phrasing of the question, you're aware that a lot of the health indicators in the state of Texas have gotten worse. So they're seeing increased rates of sexually transmitted infections, increased rates of unintended pregnancies, you know, decreased rates of cervical cancer screening, which down the line is unfortunately likely to result in increased rates of cervical cancer. So this is having a negative effect.
The only thing that I want to add to that is that it's really important to be clear about how abortion funding works when it comes to money from the government. The federal government, we have the Hyde Amendment that's been on the books for decades that basically says federal money cannot be used to pay for abortions except in very small cases. So most women who are poor and who are on Medicaid cannot use that funding to get an abortion. It's just not available for that. There are some states that create broader exceptions, and you can sort of guess what those states would be, the more sort of left-leaning states. But so when we talk about taking money away from Planned Parenthood, that's not money that was ever paying for abortion services. That was money that was paying for sexually transmitted disease screening, and money that was paying for prenatal stuff, and money that was paying for contraception. That's the money that's gone. None of it was paying for abortions.
Okay, do we have a volunteer at this table for their question?
Good afternoon. My name is Jabria Getty, and I'm from Lincoln University Grad School. If abortion is illegal in some states, why isn't contraception free?
Well, just as a point of fact, abortion is not illegal anywhere in the United States. So that Roe versus Wade, Planned Parenthood versus Casey, Whole Women's Health versus Hellerstedt, which is the most recent case, all of those cases stand for the proposition that women have a right to terminate a pregnancy. So it's not illegal anywhere. That doesn't mean it's accessible, it just means it's not illegal, right? So if you have, for instance, facilities that end up closing down because they're not getting funding for other types of work that they were doing, women might not have access to abortion services there. So actually that I just wanted to put on the table just to be clear about what the law is now, and I totally lost track.
Why isn't contraception free?
Got it.
So technically also, and so under the Affordable Care Act contraceptive mandate, for, you know, contraception should be free without a copay to anybody who has insurance through the ACA, which should be hopefully, you know, most people. There are, you know, increasing exceptions, but I think, you know, to answer your question, it's sort of is this unfortunate disconnect where in some ways contraception is sort of becoming the new abortion, in the sense that the same folks who want to restrict abortion are also oddly wanting to restrict contraception, even though it doesn't make logical sense that using contraception to prevent an unintended pregnancy would decrease the need for abortion in theory, but that's not exactly how the logic goes.
I would have only add that if you are an adherent to natural law theory, contraception is just as unnatural as abortion because you're interfering with what would happen by nature, right? The sperm would hook up with the egg, and then the fetus would come to full term. So usually your conservatives who abide by some sort of natural law or into, if they're against abortion, also might be against contraception.
Although I will just note that historically that was not the case. Historically, conservatives were pro-family planning funding because they actually realized that it made fiscal sense. And it used to be, back in the day, that every dollar spent on family planning services saved 4. Now that's every dollar spent on family planning saves 7. But that fiscal argument no longer seems to appeal in the same way it used to.
Next question?
Hi, it was 3 of us, but me now. Our question was, should there be restrictions on how many times a person can have abortions? Example, a person just having sex multiple times and they're not wanting a baby and the person is financially stable.
Is that a moral question?
It was, well, the 3 of us were basically saying that we know multiple people that should have about 5 or 6 kids now. So, should there be a restriction on
Are you asking, should there be restrictions on the number of abortions that you can have?
Yeah.
Yeah. What I think you could almost tie that question to the earlier one, because now you're using abortion as a form almost of contraception, right? Like a backup. And again, I would say that the issue of abortion involves a wider, broader issue of how we behave sexually, right? If we are engaging in sex, we should know that the chances of somebody getting pregnant might happen. So the questions are you engaging in responsible sex where you would be open to that if that happens, and if not, well then maybe you should be making sure that you're using contraception if you don't want that to happen. And because abortion involves the tricky question of whether or not the fetus has moral standing, it's a much greater moral issue aborting a fetus than it is like putting on a condom. So I would be reluctant to treat abortion as contraception. So I mean, I would say the more abortions you have, it sounds like you're treating it like contraception. I'd be reluctant to do that.
Just a few things to respond to that. So number 1, not all sex is consensual. So some of these women may find themselves in a situation where they weren't unprepared for intercourse and aren't on a contraceptive method. Number 2, contraceptive methods fail. So sometimes the reason for an abortion is that a woman was using contraception and it didn't work. And then the third point I wanted to make is just medically, there is not a problem with having multiple abortions. So either using the medications to have what's called a medication abortion, or having surgical abortions. Either way, it is safe to do that multiple times, and neither one has impacts going forward on the woman's fertility. So just from the medical perspective, in terms of safety.
Yeah, so this also makes me think, of course, this is not true for every case, but my area of specialty is in domestic violence and intimate partner violence. And so a lot of my clients who do have repeat unwanted pregnancies, it's the result of like reproductive or sexual coercion in their relationship. And so condom negotiation or birth control negotiation is not safe for them for a variety of reasons. And so those clients have come to us with multiple unwanted pregnancies, and it's really challenging because a lot of the financial and social resources that exist at that first or second situation are no longer there at your third, fourth, or fifth unwanted pregnancy. And so those folks face sort of extra layers of barriers trying to get support. So that's in the context of my work, that's where I see a lot of sort of repeat unwanted pregnancies. And it's really challenging because we do societally see that a lot of times as the responsibility, of the person who's carrying the pregnancy, when a lot of times it's actually like a super amazing survival skill that person's utilizing to stay safe in their relationship. So I think it can be really tricky. Yeah.
And I'll just add two things to that. One is, if you decide that you wanted to legislate something like that, what's the number, right? Is it 2, is it 3, is it 4, right? So you have to sort that out and decide who gets to pick that number. And then the second thing I would say is, I'm not so sure if a woman has had multiple abortions, whether the world would be better off if instead she had 5 kids that she didn't want, right? Would she be better off, and would the world be better off if that was the outcome instead?
All right, do we have a question?
Paraphrasing Senator Harris, are there laws and regulations regulating men's bodies and health care around the country and in the states?
Are there ways in which the government demands that men do certain things with their bodies? Some, right? I mean, I didn't have to register for the service when I became 18, right? So there are these sort of discrete areas, but the truth of the matter is, men don't get pregnant. Most men don't get pregnant. Some identify as trans and they get pregnant. We'll protect some. But pregnancy is a unique state. There's nothing else like it, and there's nothing else that is a process by which new human beings are created. So it's very hard for me to sort of play the game of, well, do we treat men the same way? Because pregnancy is such a unique state of being, which doesn't mean that we should regulate it in the way that we are, but I don't think that we get to less regulation by saying, but that's not how we treat men.
All right, do we have a question?
Our question is, what are the controversies for pro-abortion limitations? Where would these limitations stop at?
So I want to make sure that I'm clear on the question. Is the question, how far could the government go in restricting access to abortion?
Yes.
Okay. Well, after Roe versus Wade, people thought that it was really circumscribed what the government could do. After Planned Parenthood versus Casey, that was less so. And it's probably the case that it's becoming increasingly less so. So things that the states are allowed to do that would not initially have been allowed under Roe versus Wade, things like having a 24-hour waiting period, which requires women to go to a clinic twice, which for some women is not a problem at all, but imagine the clinic is 300 miles away from your house and you've got small kids, right? I mean, or imagine you have a job where if you don't show up one day, you just don't get paid, right? You don't have sick days to take. And now we have states saying, okay, 24 hours isn't enough. Really, we need it to be 48.
It's
And then,
72.
exactly, and I was going to say, and the next one is going to be 72. And then you have states doing things, and these are totally unconstitutional. They shouldn't all. States doing things like sex selective or abortion because of fetal anomalies. We'll tell women in those cases that they can't have an abortion. Or we have states saying, you as a clinic that's providing abortion services have to look like a clinic that's doing outpatient surgery, right? So you have to retrofit your entire facility in such a way that doesn't make sense and isn't cost effective. So what's been sort of amazing, and then we have the fetal pain laws that say now we're going to make abortion illegal at the point where a fetus can feel pain. So we have all of these things that are happening and all these steps, and it's because there's a really organized and focused movement that continues to push the line. And every time they push the line, it takes litigation in order to figure out whether they have pushed too far. And litigation is expensive, and litigation is a long process. So I couldn't say sort of where it all ends, right? I could say at this point, well, given the precedents that the court has decided, you can't just have a blanket ban on access to abortion, but you can get pretty close to that under how the Supreme Court has been ruling on these cases.
Just to add to another one of the pieces of legislation that's been proposed in some states is a fetal heartbeat bill. So banning abortion at the time of fetal heartbeat is detectable, which is at about 5 to 6 weeks of gestation, which is actually usually before most women would know they were pregnant. So that would essentially ban abortion. Yeah, for the ladies in the room who've been pregnant. But that has not been found to be constitutional.
So far.
So far, yeah.
All right, do we have a question?
My group's question was, if abortion is banned or regulated, what policies will be put in place in order to handle the already overflowing amount of children going through the foster care system?
Yeah, I mean, I can say that one of the major reasons, first of all, that a lot of my clients are contemplating pregnancy termination in the first place is financial. So we know that lack of sort of resources to a standard quality of life and lack of ability to sort of maintain more children in your household is a major factor for a lot of folks about how we even make this decision in the first place. So I think when we think about sort of overloading families that are already sort of under-resourced and marginalized in the systems that we have, yeah, I mean, that's very concerning for me. And I don't, I guess it would be a question of do we trust our legislators to care about those children once they are here? And that is kind of a personal call, and I think it also sort of depends on, yeah, your relationship with legislators in your community. Yeah, so I think it's pretty bleak, but that's, yeah.
I would add to that, this discussion is about the issue of abortion in America, but if we expanded it beyond America, there's only 1 million abortions a year in America. There's something like 55 million abortions in the world a year, so a lot more than the United States. What would be the cost of adding an additional 55 million people to the world's population every year? We already have a population problem, so.
All right, we have another question.
Since sex education has been taken out of most schools, how can we focus on educating youth about sex education and decision-making as much as the abortion discussion, as far as financial support and contraception?
Yeah, one of the programs that our agency does is called STAR, Students Talking About Relationships. And so we go into middle schools and high schools and sort of after-school programs in non-traditional school settings, and try to train young folks to be sort of ambassadors for healthy relationships among their peers. What we know is that teens are much more likely to listen to each other than to us about this stuff. And so, that curriculum was developed from a lot of evidence-based stuff, and we have found that it's really helpful in sort of training up folks who know how to have those conversations with their peers about what are red flags for if somebody's pressuring you sexually, right? What does a healthy relationship look like? Because a lot of the research also shows that teens will tolerate really abusive behaviors and think that they are normal. Things like, somebody texting you 50 times between 12 p.m. and 6 a.m. Something like 50% of teens thought that that was just fine, that maybe it's because they love you so much. So when when they hear from adults that that's abusive and that's dangerous, it doesn't really sink in the same way that it does from hearing from their friend. So we've had a lot of success in sort of going the peer-to-peer kind of train-the-trainers approach. And it also sort of allows it to not be something that the school is responsible for, because we know that school to school, it can vary a lot in how they sort of handle these things, so that it sort of becomes something that is a little bit more of a grassroots movement within the students, within the student body, and they're sort of leading these projects and these activist movements on their own. So that's kind of our grassroots way of getting around the fact that there's not a lot of kind of formalized education. Of course, we would love for there also to be more formalized at the like systematic level.
I think just to add to that, you know, that it is very unfortunate, getting at your question, that, you know, sex ed is not a formal part of most school curriculums these days, and that when it is, often it is an abstinence-only curriculum, which the government itself did an evaluation of and found that those programs were not effective, even the ones that weren't teaching inaccurate information.